Presentation, we would like to present a little bit the fascial treatment. So we will go through a little bit the anatomy, physiology, the innervation of the fascia, and we will understand why the fascia is a very important tissue for chronic pain, acute pain, and even for other type of conditions such as some kind of neurological conditions such as spasticity. And then we will present the Steco manipulation method, which is a manual therapy method that you can flip over. That was created by an Italian physiotherapist and two Italian doctors, a physiatrist and an orthopedist, which is a method that has been taught for almost 40 years around the world, and is actually one of the most evidence-based manual therapy methods and the most advanced manual therapy methods. Right now, we have more than 250 articles published on PubMed, many books, and also the only one, the first functional atlas of anatomy of the fascial system. Go over this one. We'll see this after some result. Over, Natalie. Yes. So right now, what is the fascia? Because we know that usually is a subject that is usually not taught even in postgrad anatomy course. One of the reasons because for a long time there was a confusion in terms of the terminology used to describe the fascia. The fascia is described as a sheet or a number of sheets that can be dissected that are below the skin, surround the muscle, and even the internal organs. But we will see that each type of fascia, which is still a connective tissue, has different histological feature and also a different morphology. And we will see that even each type of fascia may play a different role in physiology and also in pathology. Can you go over this one? We can recognize four main types of fascia in our body. The superficial fascia, which is the first fascia that we find behind the skin, that we will see is important, for example, lymphatic drainage, for the protection of the superficial nerves, for thermoregulation. But also, latest study from last year show that we have a lot of mast cells in the superficial fascia. Then we have the deep fascia, which is also known as the muscle fascia, which is the fascia that surrounds the muscles and create the connection between the muscles. So it is this type of fascia, especially one specific type, that allow us to understand the kinetic chain and also how a lesion or a trauma in one part of the body can create compensation and show symptoms far away from the original site of trauma or surgery. Then we have the visceral fascia, which have a very similar organization to the musculoskeletal fascia, which is different type of fascia surround the organ but create the connection also between organs that play similar functions. Then we have the nervous fascia, meningeal fascia surround the meningeal layer and also create the sheet of the nerves in our body, which is also connected with the fascia of the muscular system. And we can see in our bodies, even this image, that we have different type of fascia. We have neurotic fascia, but also the fascia of the internal organ, where we have a fascia like the visceral peritoneum, which is around the organ. Another fascia that connect also the organ within the trunk, for instance, with the parietal peritoneum. Next slide. So first of all, the superficial fascia, which is the fascia that we found more closer to the skin, which is a fascia which is very rich in elastic fibers. It's a fascia that can adapt very well to the traction in different directions, and it divides the subcutaneous tissue in two parts. This one. Here we can see the superficial fascia with the superficial retinacular cutis, the deep retinacular cutis, and deep fascia. So we can see that the superficial fascia is just below the skin. Next one. And these are some very important features we can see in the superficial fascia. In the first image, we can see the vein, the saphenous vein. So in the lower limb, the superficial fascia entangle the vessel, so it's very rich in vessels. Also in nerves, you can see in the second image, this is the area where the superficial peroneal nerve pinched and passed through a hiatus, through a hole from the deep fascia, and then goes to the superficial fascia. So the superficial nerves, when they become superficial, they are within the lamination of superficial fascia. And also in the superficial fascia, we have the lymphatic ducts. So this superficial fascia play an important role also for the venous system, because it creates a sort of protection also for the backflow of the blood. And when we have a alteration in the superficial fascia, we may have some alterations, such as, for example, saphenous vein, or also an entrapment of the superficial nerve that may cause symptoms which are quite different from, example, a compression at the level of the spinal compression. Also, superficial fascia is very important for thermoregulation, metabolic process, and also may play a role also in immune system, because right now we discovered from last year that we have also a high concentration of mast cell. Next slide. Now, concentrating on the deep fascia or muscular fascia, which can be further divided in two types. One is called epimysial fascia, another one the aponeurotic fascia. On the aponeurotic fascia, it's the fascia that surrounds many different muscles. As you can see even in this image, it creates a sort of layer over the whole limbs, as you can see even in this image from the fascia lata. It's that surround many muscles. So it's a fascia that over different muscles. It's the one that this type of fascia create what are the chains, the myokinetic chain. From a histological point of view, this fascia is a multi-layer structure. Usually we have 2 or 3 layers of collagen fiber, and between each layer, we have loose connective tissue. And in a certain way, this type of fascia that for a long time was considered a sort of irregular connective tissue has a specific organization, and actually is mechanically independent between each layer because they can glide freely. Here you can see a study that was published almost 10 years ago. It was a 3D reconstruction of the thoracolumbar and crural fascia, showing that it's a multi-layer organization where each layer has parallel collagen fiber with a single orientation. Usually this orientation will follow the traction of the muscle that are inserted in this aponeurotic fascia. Here's some other image of the deep fascia in the lower limb, the fascia lata. And then a very important concept. So we will see also in the next slide that many studies show that around 30% of muscle fiber do not insert in series through the tendon, but they are attached to the connective tissue. So there must be a reason for this. And we know that around this 30% of fiber insert in parallel through the muscle and connective tissue. Probably the function of this 30% of muscle is to create and maintain a basal tension and also activate the receptor to improve the proprioception. And this aponeurotic fascia is a sort of like a large tendon that creates insertion with different muscles. Because below this aponeurotic fascia, we have the fascia of the single muscle, which is the epimysial fascia, which is a layer that is intimate connected with the muscle. Actually, even to dissect it is quite difficult because you have to cut all the myoseptum, the insertion of the muscle, and it's a fascia that surrounds the bundle of muscle. But even with this term, we can consider also the intraconnective tissues, such as the perimagine that surround the bundle, even the endomagine that surround the single muscular fiber. And all these type of epimysial fascia have a multi-layer organization, and within each layer, we have loose connective tissue that allow an independent gliding structure. And this sliding system, gliding system allowed by the loose connective tissue is made possible by the different substances such as water, ions, but specifically one protoglycan, the hyaluron or hyaluronic acid, that allow the gliding of different structure. This hyaluronic acid is produced within the fascia by a specific type of fibroblast, which has a different feature from a normal fibroblast. Example is more rounded, and is between the layer of each fascial layer. That these fibroblasts produce hyaluronic acid through shear force. So what does it mean? With our movement, we create a stimulus that activates this type of fibroblast that we call fasciacyte, that produce the hyaluronic acid and allow the gliding of the different layer and allow the smooth movement during our daily life. Now, when we have an alteration of fascia, actually we can distinguish two types of alteration of fascia. One is the densification and one is the fibrosis. Fibrosis is what we all know, is an excessive deposition of collagen fiber, usually in a non-organized way, usually follow severe inflammation, surgery, trauma. And then we have what we call the densification. The densification probably is the less known one, but is the most common that we found in our office, in our physiotherapy service, which is a changing of the concentration and also the aggregation of the hyaluronic acid. Hyaluronic acid usually is binded with many molecules of water and acts as a lubricant. But when there is an alteration of concentration, next slide. When we have, for example, an alteration of concentration due to many different reasons, the hyaluronic acid cells start to self-aggregate, and these increase the viscosity. What does it mean? That this loose connective tissue that is in its physiological state, a liquid, a fluid that acts as a lubricant, it becomes a sort of gel, which do not allow anymore the gliding of the different layer of the fascia. We not see yet, but the fascia is rich in free nerve endings, multimodal free nerve endings, nociceptor, mechanoreceptor. So when we have an alteration of this gliding, then we have all the symptoms that we see in our daily practice, such as pain, decreased range of motion, altered proprioception, and even a maintenance of hypertone, such as we've seen in spasticity. So what can create densification and fibrosis? For sure, injuries, surgeries, radiation therapy, immobilization, but also some metabolic conditions such as nutrition, some medication, and also other, for example, long COVID or other systemic disease. So when usually we have, for example, trauma, severe trauma, surgery, or even in case of metabolic syndrome, we have to think about some alteration in the fascia. And what are the symptoms that this densification can create? For sure, pain, local pain, but also referred pain, because that fascia, as we saw before, the aponeurotic fascia basically is connected through the epimysial fascia, which is below this aponeurotic fascia, through myofascial insertion. So what happens that when we have an alteration in one area, the transmission of force is altered, and this can create also the activation of nociceptor in a faraway location. It can create also decreased range of motion, altered proprioception, and also can alter the peristalsis of the internal organ. Even the alteration of the deep fascia and superficial fascia can create edema, for example, or decrease in vascularization. Next, Natalie. So the good thing is that we know that fibrosis is quite hard to reverse. Even most of the time, second surgery is needed. But densification, on the other hand, is quite easy to reverse it even with manual therapy, because due to the characteristic of hyaluronic acid, the increase in temperature and the mechanical stress is able to allow this self-entangled cell to dissociate, to unbind, and also we are able to remove the excess of hyaluronic acid. So, next one. Now, the innervation fascia, as we said, the fascia is a very innervated structure. Now, this study that is shown here is a study that's more or less was published around 13 years ago, showing that the fascia is richly innervated by free nerve endings, but also mechanoreceptors such as pacini and ruffini. And also, each type of fascia, each area of fascia have a different concentration and different type of receptor. Another study was published about the innervation in the hip area from the skin to the capsule, showing that the skin is the most innervated structure, the superficial fascia, and then follow also the deep fascia. The type of innervation also is different than the concentration. Example, the fascia example have a different type of innervation, is rich and innervated than the muscle, for instance. This was a study that showed, example, that with the injection of the nerve growth factor in the muscle and the fascia, there is an increased sensitization pattern in the thoracolumbar fascia compared to the muscle. This is another study was published by German researcher Schindler that showed that with hypertonic saline solution in the muscle, subcutaneous tissue, and thoracolumbar fascia, the injection in the thoracolumbar fascia create a more intense pain with longer duration, also a larger spatial irradiation, showing that the thoracolumbar fascia is really a structure that is able to create nociception pain, and even of greater intensity than the muscle itself. And also the fascia create a specific type of pain that is different from the muscle. This is something that even clinically is quite easy to differentiate the two types, the origin of the pain from the muscle part, the fascial part. This is a narrative review published by Carla Stecco that show exactly that most of the time that the referred pain pattern that we see in our clinical practice, most of the time does not come from the dermatom, which also we know that the dermatom most of the time can be confusing because most of the time the patient does not come with a clear a pain that follows a clear dermatom, but it follows more the continuity of the deep fascia. What does it mean? That this continuity of the fascia through the aponeurotic fascia, when we have an alteration, densification, we have an activation of the nociceptor that can create a pain that follows this line of force in the deep fascia that you most of the time does not follow the retina. But this is also a very important topic. I really believe also for the family doctor to distinguish, for instance, if a sciatic pain is of a fascial or myofascial origin or really a reticulopathy. Next one. So the fascia is richly innervated by mechanoreceptor and nociceptor. The fascia is a pain-sensitive structure, and when there is an alteration of this fascia, we may have pain, local referred pain, alteration of proprioception, because the fascia also in its physiological state, especially a specific type of fascia such as retinaculum, play a very important role for proprioception, even for peripheral motor control. And now another interesting feature of the fascia is the presence of hormone receptor. So, next one. A study that we published in 2016 showed the presence of receptor for relaxin and for relaxin estrogens in the deep fascia, in the fascia lata, and that also different concentration of hormones can even change the fibrous component of the fascia. And this also is very important because if we're thinking, example, to a condition, example, during after breast cancer therapy, when the patient take, example, an anti-aromatase medication, a decrease in concentration of estrogen can modify the fascia and can also, of course, increase the pain due to the fact that the estrogen also play an important role in the sensitization of the nociceptor. Also in the fascia, we found endocannabinoid receptor that play a very important role for inflammation, and also for pain modulation, and they also have anti-fibrotic activity. We published also a study a few years ago showing that when we inject, example, an agonist of the endocannabinoids, we have a more production of hyaluronic acid. What does it mean? That when this is also when this endocannabinoid system work very well, we have a better production of hyaluronic acid, allow also a more smooth movement and a pain-free movement. Okay, Natalie, maybe you can continue because I have to board the plane. I'm very sorry.
Okay. Marco, thank you so much for the introduction.
Thank you for everyone.
Fascia, it's amazing.
Thank you.
Have a good flight.
Thank you, everyone. Thank you, everyone.
Bye.
Bye.
Good flight.
Okay, so actually
Thank
fascial
you.
manipulation, in that technique from Italy, we actually take all these amazing and great knowledge, and we have a manual therapy that is actually allowing us to take the history of the patient, their symptoms, and conduct a very effective, a very precise treatment for each one. So fascial manipulation has its own mechanical model, and we are first of all treating also musculoskeletal dysfunction and visceral dysfunction. So each patient will be evaluated by their symptoms, by their history. And this is something I really love in fascial manipulation because it's actually like a suit. So each patient gets its own suit. Every low back pain will be looked differently. Someone will be looked from visceral perspective and someone from musculoskeletal, all depending from the history of the patient. So as Marco told in the beginning of the lecture, fascial manipulation is actually based on all the knowledge that he already introduced. This is a science-based treatment with a lot of research evidence for its effectiveness. It's very holistic. Although it is very evidence-based, it's also holistic because it's really looking on the history of the patient and looking very, very far, very distal, very three-dimensional. In fascial manipulation, we look to treat the source of the problem, not only the site or the symptom. And we would like to eliminate the consequence of previous trauma and surgery. And I will show you a few case studies to show that. Usually we can see that it is very effective also for acute and chronic problems, for musculoskeletal and visceral problems. So this is actually a manual therapy. We are searching for densifications, the changes of loose connective tissue that Marco explained. And we take for a treatment something like 6 to 8 densifications, which are usually huge places where the fascia does not slide correctly. We treat it for manual therapy up to 3 to 4 minutes until it relaxes. The patient also feel decrease of the pain in that area. And then we check asterisks to see the before and after the treatment. So when do you need to think to use fascial manipulation? So first of all, as we said before, fascia will be, the loose connective tissue will be changing after trauma, after each surgery, after each internal dysfunction. So every patient who underwent trauma, serious trauma, and has unsuccessful rehabilitation process needs to see fascial manipulation therapist. And actually, it's not only the people and the patients who had unsuccessful rehabilitation process, but actually each patient that had immobilization or serious trauma, fracture, surgery, they will have for sure densifications. With operation, they will also have fibrosis. They have to have fascial manipulation treatment. When we see a patient that had some specific trauma, and that trauma followed by pain in other places for no apparent reason, for example, a patient who had a fracture in the tibia and fibula, and then developed pain in the knee, and then pain in the hip and low back pain, this is a consequence usually from the leg, from the trauma they had in the ankle, and therefore they should see a fascial manipulation specialist. Also, a patient with several pain in different parts, in different areas. Sometimes, in the clinic, we could consider even fibromyalgia with those patients, because sometimes we do MRI and we don't see any problem, but actually those kind of patients have a lot of pain in several places without any reason for that pain. But sometimes it's only people that will have a lot of densifications created by some kind of major trauma, major history that created consequences of a lot of different kind of pain in different parts of the body. Also, a patient with pain that does not match the bony findings. Again, no one checks the loose connective tissue usually, although we can see it, but usually in the daily practice, we do not look at it. And therefore, patient with pain that does not match the bony findings usually can just have densifications that we can eliminate. Any patient who had undergone a significant, again, fracture, surgery, immobilization, should see a fascial manipulation specialist. So here we brought two cases of patients. The first one is 38 years old male, a financial trader from South Korea. He was an amateur bodybuilder for 10 years. His main pain was sciatic pain on the left that started 3 years ago during heavy deadlifts. In the MRI presented bulged disc L5, S1. The pain was described 6 to 7, with occasional radiations toward the posterior lateral part of the leg. The patient have tried different medications without result. He has developed kinesiophobia, flexion, and hypervigilance. The pain is currently interfering with sports, with social life. He also has pain in his left knee, started after surgery in 2013. The pain present in the anterior and posterior part with decreased flexion. Left ankle, chronic instability following a severe sprain in 2012, pain during loading. Also, tensional headaches. Parietal part started 2 months ago. Pain can reach 9, 10 during period of stress and computer work. We also look the history of the trauma. So in 2013, he had fracture of the left knee, the femur, during car accident. Severe left ankle sprain playing football in 2012 that required 1 month of immobilization. So here we have severe trauma with immobilization, and which means that he will have a lot of serious, important densifications in that area. The left ankle, he said, never felt the same, and the patient is complaining of chronic instability. So actually, we have a lot of information here, but when we consider fascial manipulation, this is how our assessment chart looks. So you see that it is very effective because we have arranging all the information in a very precise, simplified way, where here is the site of pain and here is the trauma. And if we're doing a timeline, we always want to see the source of the problem, to see where the patient had this most severe trauma that started the other problems. So if we do a timeline, we see that in 2012, he had the left severe ankle sprain with immobilization, which is very important, creating densifications. Only then, 2013, he has the knee trauma, the car accident, fracture, immobilization. And then 3 years ago, he has now the sciatic pain. And also, only afterwards, 2 months ago, he had the headaches. So we can understand that in 2012, 2013, here we have the significant trauma that could cause compensation, creating the sciatic pain. So where are we starting? We're going to do a palpation between the area of the hip, which is the coxa, where he feels the pain, and the area of the geno, which is the knee, the area of the knee, because of the previous history here. Okay, geno is actually the knee. So we are looking for the movement, and then we are doing palpation of densifications in the area of the knee due to the old previous trauma and in the hip. And when we're looking for densifications, we have a specific places where we look for the densifications. They are arranged in the sagittal plane, frontal plane, or horizontal plane. 3 stars, that means that the densifications were not only bigger, but also referred pain. So as you can see here in the horizontal plane, we have the worst densification. So we took the horizontal plane, palpated few more segments, and then decided all the points that we're treating. So here you can see we have a point near the posterior part of the knee, the posterior part of the below the knee, in the medial part below the knee, also in the pelvis, and also in the hip. We have a specific organization where we should check and what we should find. We did the treatment, and here you can see the before and after. Just a second. Okay, so here you can see before the treatment, the flexion of the patient. This is his maximal flexion with pain, as we showed before. Here we can see the extension of the patient, which is, of course, very limited. Side flexion. Side flexion to the other side, as you can see again. This looks quite okay. Rotation. You can see that he's limited in the range of motion. And again, he came with something like sciatic pain. Okay. Just to check a little bit the motion of the humerus, of the area of the shoulder. Here, Marco is creating the treatment in the points we've showed. So each point is treated something like 3 minutes with manual therapy. Beginning, we feel the densification. You see like a bumpy, it looks like bump. And then after 3 minutes, it relaxes. And now the after. This is immediately after the treatment, full flexion, much better extension, much better side flexion. You can see that he's shocked by his result. And also the rotation, which you can see that is much, much better. So this is a nice example where the patient, we have an immediate, very effective treatment that can actually is considered the history, the specific history of the patient. And I think that what is important here that this patient has specific trauma from the legs that were ascending up, creating compensations and pain in his low back pain, something like sciatica. But actually, we started from the leg, and most of the points we have treated here, Marco treated here, were actually in the leg. So if this patient would get only medications that didn't help, or any other treatment which was local, maybe the solution wasn't that good. Another case study is a 42 years old female physiotherapist from Argentina, former professional Olympic javelin thrower. She still currently trains throwing and basketball at amateur level. She had pain in her right shoulder since 2 years ago with limited flexion, abduction, and external rotation. You will see it in a video, very nice. Pain intensity 5 to 8, pain worsened during shoulder movement, in flexion, abduction, external rotation during javelin throwing, basketball, and manual therapy. She also has pain in her right elbow that started in 2018 with limited extension, pain intensity 3 to 7, pain worsened when working with manual therapy and weight-bearing activities. The history of the trauma: she had a fracture of the radius and the ulna on the right side in 2005 during a motorbike accident. She used the cast for over 1 month. So again, immobilization is one of the things that create densification the most. She had a chest trauma during a basketball game 10 years ago with fractured ribs on the right side. She had a bilateral carpal tunnel surgery in 2007, 2008, and 2008. So again, this is, you can see here, all the information that I have told you organized in a very, very specific assessment chart, very easy one, very easy to look. And this is her timeline. So from 2005, she had a specific trauma of fracture in her wrist, radius, and ulna with immobilization. Then the carpal tunnel surgery, which is actually the carpal tunnel is already a compensation. Then the ribs, the fracture in the ribs, which were traumatic, very important. And then again, compensation in her epicondylitis. Again, every symptom that without a specific reason, such as trauma, surgery, and so on, we consider as compensation. And now she had, since 2021, the shoulder pain. So again, this is her timeline. So started from the fracture here up to pain here. So of course, we're starting from the history, checking the site of pain, which is the shoulder, but also the previous history with the trauma, which is the carpus. We palpate, we found the worst densifications. Here are the location of the worst densifications. In fascial manipulation, you have a specific places to search for them. We chose the worst ones and we treated. And here you can see the before and after. So here you can see before, you can see the reduced flexion in her right hand, the reduced abduction. This is also during the course Marco is treating her. And this is the end. You can see full range of motion, inflection, abduction. Very beautiful, immediate result immediately after the treatment. Something else I would like to show you is another case. Just a second. In the beginning, can you see the slideshow? So as you can see, perfect. So as you can see here, this is, remember that Marco spoke about the kinetic chains, which are actually allowing the force transmission between the different segments, between the different parts of the body, which allow more strength and the coordination. So here you can see a gymnast in the right picture, which is 2 months after arthroscopy in the hip for labral repair. And this gymnast had a problem of active flexion. You can see that she in the beginning, look at the upper part in the video. I asked her, please raise your leg. And you can see in the upper video that she can't. Immediately after the treatment, this is the before, you see, she cannot activate enough, so she cannot do the full flexion. And here, immediately after the treatment, she could do it. So we didn't have hypertrophy of the muscle in 20 minutes of treatment, but actually what we had is because of the elimination of the densifications, her muscles could recruit and transfer the force between the different segments. So every patient that has some kind of problem of rehabilitation or had a specific severe trauma with immobilization, a surgery, and then compensated for a pain in different parts of the body can be used and can be a good patient for fascial manipulation. So one more thing I wanted to show you is also remember that Marco told you that all the vessels, we have a lot of vascularization in the fascia. So this is, for example, a patient which was 1.5 years after nipple sparing mastectomy. And you can see here that she has a partial nipple necrosis in the nipple. It was already 1.5 years after. This is before the treatment. Of course, she has pain in her shoulder. She has pain in the area of the trunk, of the thorax. And after 2 treatments of fascial manipulation, you can see much better vascularization in the nipple. The nipple is erectile. You can see that, well, still you see the tattoo that she did right here to make it look better. But you can see that the skin is much better. All the vascularization around the nipple is much, much better. And again, this is maybe the strength of the method, that because the fascia is actually enveloping the vessels and the muscles and the nerves and the lymphatic system, we can affect a lot of different patients in a very severe cases that maybe other methods or other types of treatment cannot help. So, thank you very much for this Zoom. If you have any questions, I will be happy to answer.
I'm Yaakov from Israel. Can you hear me?
Yes, I can hear you. Hi, Yaakov.
It was a very interesting lecture. Actually, we are more interested in to know how practicality, how to convey to our patients. So that may be the introduction. Maybe another course will be more practical one.
Yes, of course. Well, actually, this method, again, it has 3 stages for musculoskeletal and visceral. We have a lot of doctors in the courses that imply the method in their offices. Of course, this is just to show, because I think that the basic knowledge of densifications, of even to understand that the loose connective tissue is changing, not only to consider fibrosis, but densification, which is a reversible process. I think that this is a very interesting information to understand that we can help the patients also in this way.
I have a question.
Yes.
Thank you. Thanks for an excellent talk. It's a fascinating subject, and I have a lot of experience with shoulder fascia. And I'm wondering, some of the results you're talking about are localized, fascial changes, chain changes, sort of local tissue changes. Have you got any thoughts about more of a central processes, more sort of reflexes or neurological processes centrally that are going on rather than just local or reflex arcs?
Well, actually, yes, it is being investigated specifically by Antonio Stecco, Professor Antonio Stecco, in New York University. So yes, he did a few surgeries also on neurological patients with more central.
I'm thinking about the effects, because I'll tell you what I mean, because some of your before and after effects can be from pain inhibition. So there was a patient with pain inhibition. I mean, I've just noticed myself that sometimes when you're working on the fascia and you release the pain inhibition, people's range of motion comes back. And I would say that that's more of a central a reflex rather than a local tissue. I'm just thinking of that idea.
I think, well, yes, I think that more research should be done in that area. And for sure, you can contact Professor Carla Stecco, maybe to investigate this.
Okay. Thank you.
Thank you.
And if there are no more questions, maybe we should close as well. Thank you again for very interesting. And by the way, the captation and everything will be edited so that people will be able to watch it and even have translation in their own languages. We are working on that. As soon as this will be finished. So thank you very much, and for the cooperation between Israeli and Brazilian Circle of Pains, and thank you also for Marcus, the head of the Brazilian Circle of Pain.
Thank you.
Sure. Bye-bye.
Bye.
Thank you.
Bye-bye.
Bye, Natalie. Bye.
And we're looking forward to hear from you more.
Good.
Thank you.
Thank you. Bye.
Bye.